And so we have, so for those that don't know me, I'm Dr. Donald Jurovich, professor of geriatrics at the University of North Dakota and a consultant physician at Sanford South Point Internal Medicine and Geriatrics Clinic in Fargo, North Dakota. So quite honestly, this first slide that I'm showing here, this is the car I wish I had to travel back and forth from Grand Forks to Fargo. Be nice to have a little Tesla Roadster. But today we're going to do a little bit of an abbreviated presentation. I have a lot of slides here, so I'm going to get through what I can get through, mindful of the hour, and we'll do our best here. We'll have these slides posted, and also there will be a video recording of the full presentation. All right, so one of the things that we want to talk about is, in terms of the older driver, is to fix what you can and monitor the rest. We want to start the process of driving safety and driving cessation. Stop driving, when you take away the keys, and that's an ongoing process. It should not be done immediately. So the good news is that most older drivers drive safely, as we can see with Mr. Magoo, for those who may be dated like myself, who remembers this cartoon. Mr. Magoo was a little nearsighted, so he often got himself into trouble. But the point is that there is self-adjustment for the older adults. You want to make sure that that the patients identify that they've made these adjustments, because again, it's an ongoing process. But a lot of times, because of night vision and so forth, they may limit their driving, won't go on highways. Although I have to tell you, I was driving up and down I-29 going north, and there was a older adult very menacingly looking at his steering wheel, driving the wrong way on the northbound road. Clearly trying to get somewhere, but poor guy just missed his exit. So we had to call the sheriff to try and round him up. So the question is the adjustment time appropriate, or is it too much? Is it inadequate, in terms of the changes that we're looking for driving? And even though that there are these concerns about changes in driving habits, the good news is that because of automotive safety, seatbelt mandates, and Wile E. Coyote here launching himself, he's burning his tail instead of the fire rocket there to beat the Roadrunner. But the point is that we have been seeing a decrease in injuries and fatalities. So again, fewer crashes, improved survival. Although I have to tell you that for each type of crash that occurs, usually the older adult does not do as well because of lack of resiliency. And you can see here that there's been some recent change in the crashes, per 100,000, and they've gone down basically. And the biggest one, actually interesting, is in the 80-year-old and older group. It's been a 40% decline in crashes by drivers that are that oldest old. The licensure rates have changed also, so more people are driving in the older age group as time goes along. So that's just an interesting point. So we want to talk a little bit here about a case report. We have a 74-year-old lady with stage 4 kidney disease. She has diabetes, hypertension, and depression. She's had progressive decline in memory with poor motivation, and she has daytime somnolence. She sleeps a lot. So for treatment, she's been getting antidepressants. She's been getting erythropoietin for anemia, which, by the way, doesn't work. Well, it works for getting the blood up, but it doesn't help so much with fatigue. But she's noticed to have further cognitive decline. She becomes dependent in her instrumental activities of daily living. In terms of her driving status, she had an episode of running a red light. Family members don't want to ride with her. And in the clinic, she had an 18 out of 30 mini mental status exam. She was advised to stop driving. And so the question is this good enough? What was this whole process, sufficient transition for the individual? And, makes you wonder, what the response might be. So for her, because of her kidney function, dialysis was started, but she's becoming more frail now, even though with the dialysis that her cognition improved a little bit. I don't know if that's statistically significant, but it puts her into the mild category rather than severe. And she starts driving again. But the issue is predictable. Her cognition starts to decline once again. So this is for those that recognize this red box here. This is the Trail B test. And you have to connect the 1 to the A, 2 to B, 3 to C, and so forth. And it should take you, I believe, less than 3 minutes to do this. So her reassessment, you can see the mini mental status decline back to where she was before. And so she had loss in executive function by not being able to do this Trail B test. This Trail B test looks pretty straightforward, but honest to gosh, if you've got cognitive impairment, this is a major problem. And perhaps of all the different tools that we have for understanding driving assessment ability or loss of that ability, it's the Trail B test is the most likely to identify loss of executive function that's needed for driving. So it just is a word to the wise that if you use the Trail B test, it's a good test for screening and setting the basis for driving or driving cessation. So in this individual, dementia was diagnosed. The discontinuation of driving was reinforced, and we had the family there. So at least in North Dakota, you can send a message into this North Dakota Department of Vehicles or Transportation, expressing concerns about driving, and then they will take it from there. If you're a healthcare worker, you always want to remind the older adult that if they're having driving problems, that it's not you yourself that makes the determination. It's the licensing bureau that does so. And so you just really have to reinforce that we're not taking the license away. We're just advising the license bureau, and they'll either do a road test plus a written test. And sometimes that just is so intimidating to the older adult that they just decide, well, it's not worth their time and effort and potential embarrassment. So in the course of evaluating the patient, we want to certainly ask about the driving history. We want to ask them, have you had any near misses? You want to have family members corroborate that. Do people honk horns, any citations, warnings, and so forth. And then you also want to consider the driver's factors, such as, are they taking medication? Are they also having those 2 martinis, which turn into, it's the 2-for-1 rule. For every martini that you drink past the age of 65, it turns into 2 martinis. Because of the alcohol retention that occurs with the, particularly in this individual with failing kidneys that we were talking about. You want to look at functional impairments. Is there profound hearing loss? So would they be able to hear a siren? Is there vision loss of peripheral vision? So we know that peripheral vision goes down by from 180 degrees to 160 degrees to 120 degrees. So there is loss of the peripheral field of vision. And then we want to know, the reflexes, their driving performance, and the type of vehicle they drive. Is it appropriate or not? People shrink as they get older. Sometimes I've seen people who just can barely get their eyes over the dashboard, so that's something to consider. So the first question is, does the patient still drive? You want to know how often. And for what reasons? So sometimes it's very limited. Just had a patient the other day who just wants to drive to the dog park, turns out the dog park is a half a mile away, which is a perfect distance for walking the dogs. And then also just, to ask about the circumstances that they drive. Have they self-limited? So again, you want to look for adverse events that have occurred. Getting lost is a big issue. Are there any concerns with family or friends? As we saw in the case report here, some of the family did not want to ride with the older adult, so that's an indicator itself. And then I remember as a child, my grandfather was always the angry bird driver. He would always be honking on the horn, get out of my way, get out of my way. And at that age, I didn't realize that he probably had early dementia. But looking back now, it was behavior that clearly was linked to a cognitive impairment. One of the points that I try to emphasize are the cost of car maintenance. If you add the insurance, the $1,000 a year, if not more, for car maintenance, now gas, it's cheaper to take an Uber for the amount of times that people have limited themselves in their driving. If they just need to go to the grocery store, they'll save oodles of money by just taking an Uber. So it turns out that alcohol is not as big of a role in crashes with older adults, but again, you have to be mindful of the fact that alcohol does have and can have a more profound impact on the older adult because they don't metabolize it as well. And then people that are on central acting agents, so things like Xanax and sedatives, those are all opioids. Those are all real concerns for just driving alertness and reflex time. And I often put the hypothetical question there, if they have grandchildren, if your grandchild jumped in front of your car, do you think your reflexes are fast enough to stop and prevent you from running them over? And sometimes that puts it and brings it a little bit more closer to home. We've got the 3Ds of medications and driving. So generally with medicines, we always want to, when we start something, we want to start as low as dose as possible. In terms of duration, we want to avoid driving initially, and some of the medications, particularly with antidepressants, opioids, and sedatives, right? You want to explicitly tell the older adult, we don't want you driving while you're getting used to these medications. So the big issues with driving in older adults are things like memory loss, stroke, arrhythmias, and syncope or loss of consciousness. Same thing with diabetes and hypoglycemia, and then things like arthritis with stiffness, particularly in the morning. These are all considerations that we need to take into account in terms of assessing driving safety. This is a big one. I actually was involved in a couple of law cases, legal action that was taken against older adults for falling asleep at the wheel. And so this happens with sleep apnea, and somebody can just get somnolent and just fall asleep at the wheel. And in the case that I was providing medical information for, the older adult was diagnosed with sleep apnea, but unfortunately had run over a motorcyclist it was a fatal event. And then, some of the other things that we need to think about are passing out episodes, syncope, and then behavioral issues. So people with subcortical dementia, for example, so multi-infarct dementia or vascular dementia, may be predisposed to anger syndromes and rage. And as I was giving my grandfather's example, it is quite possible that that's what he had, because he was always angry, at least when he was driving. So there are some resources. This is the clinician's guide from the American Geriatric Society that you can buy online from the American Geriatric Society. And this is pretty much a plan for older driver. We call it safety, not driver cessation, but you can see the screening, the evaluation. We use the occupational therapist's driving safety program at where I work at Sanford Healthcare in Fargo. And we want to go through all these different assessments, so this is typical geriatric assessment, looking at psychosocial, cognitive, and physical abilities. So for vision, I had mentioned that the visual field cut, but also remember the contrast sensitivity declines with increasing age, and that's why a lot of people limit their driving to daytime only. And you want to get visual field or visual acuity identified with glasses, right? So you want to be at least 20/40. In terms of physical exam, you want to look at range of motion of the neck in particular, and have them flex their head upwards and turn to the side, because sometimes by doing that, you can evoke a syncopal episode with vertebral basilar artery insufficiency. And cognition, so we're always looking for attention span. Most important on this list is executive function, as measured by the Trails B test, but also drawing a clock is another executive function test. Here's one of the tests here that's timed, and you have to identify as many of the numbers as you see per each line. And similarly, here's just an example of a patient who's got some correct and some not so correct. Trail making test, there's different iterations of this. Kind of an interesting aside, the Trail B test was designed by the US Army just pre-World War II. So it's a really, really old test. And the reason that they use this test is to identify the 4 F'ers, the guys that didn't have enough ability to connect all the dots here. But it's a good for a cognitive impairment test. And so the norm is 180 seconds to complete. And you can see this guy only got it basically 3 minutes, was able to only get to six items here. And it's like he's taking the pen off the paper and so forth. So this is another test that can be used, symbol digit modalities. You can check them off, and put the numbers in according to that key up above. And just as an example here. So dealing with the problem, so we've dealt with just pretty much healthy aging, but also concerned about the dementia component of driving. And the issue is that dementia is not a 100% reason to stop driving. There may be some mitigating circumstances. Maybe they live in a rural area, maybe they've retained a lot of their driving sensibility, visual spatial reactions. And so, you can have mild cognitive impairment and still be able to drive. But the point is that as the cognition worsens, the more that the driving performance declines. And so that's what you have to be mindful of, is when do you identify that point of, no return? So part of the game is to make sure that the older adult is aware of their functional deficits and that they acknowledge some of their driving issues, and so that they can be addressed along with the family member. And then to try to make adjustments to the driving and, the driving patterns, or, the routines. So for example, we had a patient, the dog park lady, she also went to visit her sister in a long-term care facility. And so we thought that maybe that distance, because it traversed several larger roads, usually older adults with dementia have problems negotiating boulevards. If there's traffic separated by a boulevard, for whatever reason, that just causes a lot of havoc with their ability to recognize things. And so that's where they end up getting in accidents and indecisions. So there are some driving tests. The question is whether there's a bias. And so sometimes states require driving tests that are not particularly age elderly specific. They start at the age of 40, as opposed to, after age 65. In terms of driving performance, you always want to encourage a family or friend member to ride with the patient and look at these questions and report back to you if possible. There's, as I mentioned, there's the professional evaluation by the occupational therapy programs, and they do both off-road and a simulator test. The simulator test is probably the best one to use if you really are, very, very concerned about an older adult's driving capabilities. In terms of intervention for enhancing driving safety, certainly deprescribing sedatives, opioids are important. Correcting functional impairments, certainly looking at vision, low vision clinics and so forth. And then just building driving skills. So, AARP has a driving enhancement course, and so there are programs like that. So if we look at the literature, there are some evidence-based interventions where these looking at cataract surgery helps improve driving abilities. And so things like cognition, that the speed with which somebody processes their thinking can also be an indicator of either good or bad driving. This is a big one in terms of physical ability. I always talk about reaction time, and so occupational therapy programs will measure reaction time and put it in the context of the average that you should for age, because as you get older, your reflexes slow. It actually reminds me of visiting the city of Toronto in Ontario, Canada, where the Science Center has a reflex speed machine, and so I was playing with that with one of my grandchildren, and I felt pretty good because I was faster than my grandson, so that was pretty cool. 60-year difference between us. In terms of education, we talked about the driving course, that works, helping improve self-awareness. That helps improve driving safety. In terms of raising the issue in of itself, and so that should be part of when we try to practice these geriatric 4Ms, you can include driving issues either in the mobility plan or in the what matters, in the questions that we ask there. So the whole point is that we have to do the assessment. We have to ask if they're still driving. So my question is, if I see somebody that's there at the clinic by themselves, I said, how did you get here? Oh, my husband drove me, or I drove myself, or somebody brought me over, or a drive, the facility, the assisted living facility had a bus. So then you get a little bit better sense of, how they're driving, or what they're doing for transportation. So some of the questions that we also want to ask is, some of the things here on how these limitations are going to affect their safety. Are there more intense things that we can do? Again, trying to balance benefit from the greater good. And we always want to advise, the individuals, as well as trying to involve their family members in that. It can be an adaptive process. But sometimes people just, the adaptation is not there. The final bottom point here is that you can report your findings to the licensing agency. And again, let the patient know you're going to do that. Just don't do it on the sly. I had a bad experience in the Veterans Hospital back in Chicago where I thought I told the veteran that I was going to notify the driving license bureau about concerns about his driving. But in any event, a couple of weeks later, he comes back and he's looking for Dr. Jervich with his 6-shooter tucked into his belt, and we had to get the security guards to take his weapon away. But there have been providers who have been shot and killed in the process of what's perceived as a delicensing encounter with the older adults. So just be very mindful of that. Yeah, so this is just talking about the veterans. There's a report from 2017 that talks about the whole issue of driving. So you can take a look at that, and it lists some of the factors that lead to driving cessation. And I want to bring up this middle point of increased costs. Sometimes for the amount of driving that an older adult's doing is just not worth the cost anymore. So what happens when people stop driving? They can get depressed, so we have to be mindful of that. They become less active, and there's an increased trend towards nursing home. Now, whether that's cause and effect is one question, but we would like to have people age in place. And I think a lot of times when you take away the keys, they think, oh, that's it, I'm done for, and they just don't have an alternative plan, which is part of the process that we need to address as to what do they transition to. Excuse me. So this is from the Hartford Foundation. These are the different warning signs, that you can take a look at. We'll have these slides posted. So if you want to copy the slide for your own references in the clinical setting, that would be fantastic. I had mentioned earlier about the AARP, the driver safety course. I haven't looked at the price for it recently, but it was, I believe it was a nominal cost. There's other resources. There's a self-assessment here you can see for the National Highway Traffic Safety. We've got the AAA Foundation, the Driver 65 Plus. This is a pretty good program. Again, it's a self-rating tool. And for family members, there's the North Dakota Department of Transportation has some resources. And I had already mentioned about occupational therapy driving. I've not done a survey across the, at least in North Dakota or South Dakota, to know all the hospitals that have an OT driving evaluation, but I do know there is one in Fargo that we use quite routinely. Online resources, again, the AAA Roadwise Driver. So that's a program for strengthening your driving skills with age. I believe you get an insurance discount if you complete that course. Mentioned, at least for the our Minnesota partners, that there's a older adult driver improvement course. So they, of course, they show a 20-something-year-old picture, right? That's to encourage all the older adults to get their driving test. I don't know what the subliminal messaging of that one is, but there it is. In terms of federal programs, there are, I mentioned already, the National Highway Traffic Safety Program. There are other resources from the Alzheimer's Association and at the Crossroads, for the cognitively impaired older adult. And here's a few more. This is from the Hartford Foundation, so some of the insurance companies. So getting to the whole point of how you take away the keys, of course, I actually, this tow truck picking up the car and driving off with it is something I've actually prescribed to a friend whose mother-in-law was developing dementia and had to have the not only the keys, so the keys to taking the keys away didn't work because she kept finding a new set of keys, so they had to literally tow the car away and just say it broke down. So here's the cost. I don't know, these are quite a few years ago, so I think the costs have gone up substantially for the annual cost of driving. It's probably closer to the average now is closer to $10,000. Of course, when you're filling up your pickup truck, with $150 to $200 worth of gas these days, I think you'd rather be this guy fishing in the along the river here. So one of the things is that we have a duty as providers to report driving issue. So some of the states have mandatory. It's voluntary here in North Dakota, I believe, and most of the states have increased frequency of license. So every 5 years, for example. And I don't know, this poor dog's eyes are popping out of his head for whatever he sees up in front there. So here's some additional resources. Again, these slides will be available so that you can download these things and take a look at your leisure. So in terms of driving, just to some of the summary points is that we want to ask about adverse events, any difficulties that the older adult has, really do a deep dive into their medical conditions, other things that might impede driving, such as frailty, cognitive impairment, arthritis, speed. So if they have slow gait speed, remember I've always talked about gait speed. If they have a gait speed of less than 0.7 meters per, or even less than 1 meter per second, there's some serious concern as to whether their driving skills are up to par. Always engage the family member to make observations. Had a patient that we're trying to do driving cessation with, and the spouse was just totally disengaged, didn't want to be bothered. And I'm not quite sure why, but it was just kind of interesting in terms of the relationship between the two family members. So sometimes you have to get other family members involved and have a family meeting. So always be transparent. Discuss why you're making the recommendations and why there's change. Ideally, you would like to have the patient make the decision, and rather than a licensing bureau making it for them. And again, it's a slow process, quite honestly, and you really need to get the family members to help you out with this. It's always important to look at different sources of transportation. Sometimes a referral to a social worker can help facilitate that. Again, relying upon Uber, Lyft, taxis. There are some programs around the country where there's volunteers that have transportation. You can dial senior transportation also from some city programs and so forth. So again, here's some links. There's some resources here of how to take the keys away. You can see those there. And they're from various professional organizations to the University of Utah there at the bottom.